When the upper aerodigestive tract fails, the ability to swallow disappears. But beneath that obstruction, the lower gastrointestinal tract often remains perfectly functional. In this precise scenario, the surgical mandate changes. The immediate goal is no longer curing the underlying disease. It is ensuring the patient survives through sustained artificial nutrition. Bridging this anatomical gap requires enteral feeding access, a physical surgical intervention to deliver nutrients directly to the working gut. Looking at this split clinical diagram, clinicians have two primary pathways to reestablish this connection. They can enter directly at the stomach on the left, or bypass it entirely to access the jejunum on the right. Choosing between these routes is dictated by strict anatomical constraints and the patient's individual risk of aspirating food into their lungs. Any artificial entry into the gastrointestinal tract introduces a permanent vulnerability. Surgeons must precisely match the access site to the patient's exact physiological limitations to prevent complications. This is a gastrostomy. The procedure creates a direct, long-term communication tract between the anterior abdominal wall and the stomach. This route requires two distinct preconditions. The patient must be unable to safely swallow, but their stomach must remain structurally intact and capable of digestion. Neurological failure is a primary driver, specifically severe dysphagia resulting from extensive strokes or progressive motor neuron disease. Structural blockages require the same bypass. Head and neck malignancies or dense esophageal strictures physically seal off the upper tract. It is also utilized in critical care for prolonged nutritional support in ventilated patients, or occasionally reversed to decompress the stomach by venting gastric contents. Creating this stoma requires specific architectural solutions to safely breach the stomach wall. PEG is the modern standard, guided by an endoscope shining from the inside out. For open laparotomy, the Stamm technique inserts the tube directly perpendicular to the wall. Alternatively, the Witzel technique folds the serosa over a flat tube, creating a tunnel to suppress leakage. If obstructing tumors prevent an endoscope from passing, a radiologically inserted gastrostomy is performed under fluoroscopic guidance. Laparoscopic approaches offer another minimally invasive surgical alternative. While PEG is the standard, every technique serves the exact same mechanical purpose: safely anchor the tube and establish an absolute seal around the visceral breach. Opening the digestive tract to the external environment introduces severe risks, which emerge in distinct early and late phases. Immediate postoperative threats include acute bleeding, infection at the stoma site, accidental tube dislodgement, and collateral injury to surrounding organs. But the most dangerous early complication is peritonitis. This diagram shows the surgical seal failing, allowing highly acidic, bacteria-laden fluid to escape and pool into the sterile peritoneal cavity, triggering a massive, life-threatening inflammatory response. If the initial seal holds, a different set of chronic complications can emerge over months of long-term feeding management. Mechanically, the tube can become blocked by coagulated nutritional feed, or the stoma itself can widen over time, causing external leakage. Physiologically, patients remain vulnerable to gastric ulceration at the internal insertion site, and aspiration pneumonia if stomach contents reflux up the esophagus. PEG tubes specifically carry the risk of buried bumper syndrome, where the internal retention plate erodes into the gastric wall. Furthermore, if any tube is permanently removed, a persistent fistula may form. The entire procedure relies on an impermeable seal. If that seal fails, or if the stomach's reservoir capacity triggers reflux into the lungs, an intervention designed to sustain life can rapidly become fatal. When the stomach is compromised, the entry point must be lowered. We descend past the bypassed stomach, through the pyloric sphincter, targeting the jejunum below. This lower access is required for severe gastric outlet obstructions, or when the stomach has been altered by previous post-gastrectomy and esophageal surgeries. Physiologically, it bypasses the stomach to protect against pancreatic enzyme stimulation during severe pancreatitis, or to navigate around major abdominal trauma. Crucially, it is used for patients at an extremely high risk of aspiration, where keeping nutrition entirely out of the upper tract is the primary directive. Surgically accessing the jejunum requires highly specific techniques due to the paramount need to prevent small bowel leakage. The most commonly performed technique is the Witzel Jujunostomy. The tube is laid longitudinally, and the serosal layer is meticulously folded and sutured over it. As fluid travels, this embedding prevents internal leakage, guaranteeing a highly secure access tract. Surgeons may also utilize needle catheter placement during major intraoperative procedures, perform formal open surgical jujunostomies, or rarely attempt percutaneous access. Moving past the pylorus sacrifices the stomach's natural storage capacity, but it buys crucial protection for the pancreas and the airway, demanding advanced tunneling techniques like the Witzel to secure the narrow bowel. Bypassing the stomach does not eliminate risk. The jujunostomy introduces its own distinct profile of complications. Early complications closely mirror gastric access. They include accidental bowel injury, acute bleeding, and local site infection. And just as with the stomach, if the surgical seal fails, the resulting intestinal leakage leads to catastrophic early peritonitis. Late complications are driven by the anatomy. The narrow tube is prone to chronic blockage. Furthermore, continuously pumping hyperosmolar feeds directly into the small bowel often triggers severe diarrhea and rapid electrolyte disturbances. Other chronic risks include physical dislodgement of the tube, the rare occurrence of total intestinal obstruction, and persistent fistula formation. The narrow caliber of the jejunum inherently amplifies the risk of physical blockage and osmotic diarrhea, demanding precise, continuous management of the artificial feed. The ultimate decision between a gastrostomy and a jujunostomy comes down to a physiological trade-off, utilizing a natural reservoir versus securing absolute airway protection. This split-screen simulation illustrates the difference. On the left, the gastrostomy leverages the stomach's natural expansion capacity, allowing for rapid, high-volume bolus feeding. This bolus capability perfectly mimics normal meal pacing, making gastric access vastly better tolerated for long-term, home-based nutritional support. The primary flaw, however, is anatomical vulnerability. There remains a persistent risk that gastric contents will reflux up the esophagus, causing pulmonary aspiration. Looking at the jejunum on the right, the reality changes. Lacking any reservoir capacity, it strictly mandates a slow, continuous feed driven by a mechanical pump. But the jujunostomisty's supreme advantage is safety. By depositing nutrition entirely post-pylorically, it neutralizes the aspiration risk, making it critical for neurologically compromised patients. First, percutaneous endoscopic gastrostomy, or PEG, remains the undisputed most common form of gastrostomy. Second, when an open approach is mandated, the STAM technique is the standard surgical gastrostomy method. Third, the Witzel technique is the most widely utilized surgical method for securing a jujunostomy, relying on its tunneled approach for safety. Fourth, across both anatomical sites and all surgical techniques, peritonitis stemming from fluid leakage is uniformly the most dangerous early complication.